So Leslie's asked me to talk about medications, and I'm going to talk about 4 in particular because they are the commonly used ones. So next slide, please. So what we have to remember is that in the group of patients that we use medications on, a lot of them are young women of childbearing age. So the advice on preconception, pregnancy and breastfeeding is really important. In our clinic, we advise that they don't take anything during any of those scenarios because it's really unknown what could happen to the baby. And most of the time, a lot of these patients get referred to the cardiology obstetric team anyway. Next slide. So the first drug that we tend to use in patients with orthostatic hypotension, so again, like we said earlier, we're looking for evidence to support that they need this drug. So we tend to use fludrocortisone first. However, it's much more effective in patients where fluid and salt have really helped, because the whole job of fludrocortisone is to retain fluid and salt. There's a lot of anxiety about the fact that it's a steroid. We are assured by the pharmacists and the metabolic bone unit that the amount of steroid in fludrocortisone is absolutely tiny, and that it shouldn't have an effect on anything, including bone health. So we usually start at 50 micrograms once a day. You take it in the morning. Lots of patients we find take it at night, which means the maximum effect will happen overnight, which is not when you want it to happen. You want to get the best effect during the day. Now, fludrocortisone can decrease your potassium and magnesium, so it should be checked 1 to 2 weeks after starting. And then the information on the drug says that you should have regular checks of UNEs and magnesium. Now, what regular means is anybody's business, really. What we decided with our pharmacy department is that they should be checked every 3 months. And it really is important, because we've had patients sent to us. I can remember one chap, he was on 16 slow sodium tablets a day, which A, is above the recommended dose, and B, slow sodium tablets can be very corrosive to the gut, and so using dietary salt is always preferable. But his potassium was 2.8 on 300 micrograms of fludrocortisone. Well, he didn't take very kindly to us asking him to decrease both, I can assure you, but that should have really been checked. So for us, our maximum dose is 200 micrograms, and then we'll move on to midodrine if it's not really effective. Good amounts of fluid and salt are essential for optimal effect with this drug. If you're not taking much fluid and salt, it's not really going to work very well at all. There are lots of side effects, the biggest one being headaches, we find. Because a lot of patients have headaches anyway, that can be a problem, but you don't know until you try it. And quite often patients with orthostatic hypotension have headaches because of low blood pressure. So you don't know till you try it whether it's going to make the headaches better or worse. There are lots of other side effects, but that's the one that we see most of in clinic. Denise, could I have the next slide, please? So midodrine, this is the biggie, and these are the contraindications to midodrine. We get patients come to our clinic being told that the midodrine doesn't work. And first of all, some patients are on it when they shouldn't be because they've got one of these contraindications. And secondly, it's not being used properly. So it's quite a specific drug, midodrine. You can see the contraindications. Denise, can I have the next slide, please? So midodrine is very short acting, and what it does, it enhances smooth muscle tone leading to peripheral vasoconstriction. So first of all, you need to have evidence that the patient has a postural drop. We very rarely use it empirically because it can cause a few problems, although it can be absolutely life-changing. So the dosage is 2.5 milligrams to 10 milligrams every 3 to 4 hours, 3 to 5 doses a day. Now, the thing about midodrine, it's so short acting that you cannot take it 3 times a day at breakfast, dinner and tea because it just won't work properly. So what you need to do is get the patient on the midodrine, and we usually start off with 2.5 milligrams, ask them to take it half an hour before getting up because it takes sort of 20 to 30 minutes to work, and then 4 hours, 4 hourly thereafter. And then we ask the patient, did it work and when did it start to wear off? And then when they tell us that it only lasted 3 or 3.5 hours, we get them to take it so that they're taking the next dose, and we try to time it just before it's starting to wear off. So they might be taking it 3 hourly. We get lots of patients referred to us and they're taking it 4, 5, 6 hourly. And of course, they're saying they're getting dizzy, but actually when you quiz them about it, they're taking it with their breakfast, so they're not taking it before they get out of bed. So they've got sort of like this period when they've got to get in the shower and they're becoming hypotensive and passing out or feeling like they're going to pass out. And then when it's wearing off, then they get the symptoms back again. So the timing is the most important bit about midodrine. You can give 2.5 milligrams, you can give 10 milligrams, and it will still only last 3 to 4 hours. So the dose goes up once you've got the timing right. And the last dose should be taken 3 to 4 hours before bedtime. And that's because you can get supine hypertension with it. Now, I have to say, in reality, I don't think I've seen this. I have seen patients come to us on 10 milligrams of midodrine 3 times a day who have blood pressures of 160/90 because it's never been checked. I have got a slide on the monitoring, but it is really important to monitor the effect of midodrine. The other big side effect that we seem to see is urine retention. Now, this usually presents not in the patient not being able to pass urine, because often they're quite thankful that they're not having to pass urine so often with the amount of fluid they're taking, but they get urine infections because they're not emptying the bladder, and therefore you've got germs breeding, and so they get urine infections. So that is the thing that would trigger you to think that they've got urine retention with it. But what we generally tend to say about the urine retention is that it's really important to have a wee as the midodrine's wearing off, as the dose that you've taken is wearing off, empty your bladder and then sit there and then empty it again to make sure that you've not got urine retained in the bladder. Now, sometimes it can be difficult for patients who are hypermobile because they have big overstretched bladders and it's quite difficult to empty. So you do have to be careful. But I think if you're attentive to the details about it, you can usually avoid a problem. Next slide, please, Denise. So for patients with a symptomatic tachycardia or postural tachycardia, the first line drug that we would use is ivabradine, 2.5 milligrams QDS every 4 hours. It's not licensed for use in autonomic dysfunction, so we find that often has to be started in secondary care because GPs often won't prescribe them. It doesn't tend to be effective in AF. I mean, to be honest, our group of patients that we see don't tend to have AF, but it does work within the sinoatrial node. So obviously in AF, you've got no impulses coming from there. The fantastic deal with ivabradine is it slows the heart rate without having an effect on lowering the blood pressure. But with most drugs for patients with autonomic dysfunction, the little and often work really, really well. So 2.5 milligrams taken 4 times a day, every 4 hours, works so much better than 5 milligrams BD. Side effect wise, there's lots of sort of non-specific side effects as with most drugs, but the one that seems to sit with ivabradine is the ophthalmic side effects. I think I've spelt that wrong actually. And in that patient's in the dark, sometimes like a sort of halo.
I'm not sure if we've lost Mel or if it's me that's dropped out here.
No, she's frozen. She's frozen, yeah.
Yeah, I'll maybe just give her a quick ring and ask her to log in again.
Yeah.
Are we all there?
Got you back.
What happened there?
You dropped out.
Just froze.
Well, that's the NHS's broadband for you. Can I have the next slide, please, Denise? So lastly, I was going to talk about beta blockers. I think we're all familiar with the beta blockers in that they slow the heart rate, but unfortunately they have the side effect of causing hypotension. And we often see this with patients who are started on beta blockers, and actually the low blood pressure is driving the high heart rate, and it makes the patients feel worse. Again, short-acting, small, frequent doses are most effective with this drug. So like propranolol, 10 to 20 milligrams, TDS, old-fashioned beta blockers, obviously side effect profile, the ones with the lipophilic action, the old-fashioned ones can cause disturbed sleep and nightmares. We don't tend to see that often, but I do remember when I first started in cardiology, which is a very, very long time ago, before thrombolysis, the short-acting beta blockers had a big effect on people's sleep. Because that's all there was. Atenolol hadn't even been invented in those days, I'm afraid. So that shows you how old I am. Right, so last slide, please, Denise. So monitoring. It's very important, I think, in these patients that you don't start them on a drug and then leave them. So what we tend to do is see them 4 weeks for midodrine, 6 weeks for fludrocortisone after starting the drug. And we continue to follow them up until we've tweaked and they're stable. And then they go on a 6-month or a 1-year follow-up. So each appointment, it's really important to ask how frequent the symptoms are. So are they having symptoms daily, weekly? If they've got better, has the drug helped? Are there any side effects? Every appointment, we're checking fluid and salt intake. And then the other thing that can happen is patients start new medications by somebody else that have an effect on everything that's happened, such as I had a patient on midodrine, and then someone has started them on clonidine for sweating. I don't really understand why someone would start someone on clonidine, which is an aggressive antihypertensive, when someone's on midodrine to raise the blood pressure, but there you go. And of course, she started passing out more. And I think it's really important to check the drug list every time you speak to the patient. So blood pressure monitoring is really important, particularly with midodrine. And I have looked at a few policies recently to see what their policy about midodrine is. And there is some blood pressure monitoring, but not much. But also what I've noticed is local policies around South Yorkshire are not even saying about getting the timings right with the midodrine. So it's no wonder it doesn't work properly. We do a 24-hour blood pressure when the midodrine's on board and stable, and then we do a yearly one. It's really good. You can see when the midodrine's being taken, the effect, and when it's starting to wear out the system quite often on the blood pressure profile. And also we can check that they're not getting hypertensive, which, like I say, can happen, but in my experience, not very often in this group of patients. And then blood tests, obviously for fludrocortisone, every 3 months is what we do, but we would do blood tests anyway every year. So for midodrine, you need to do liver function tests. For fludrocortisone, obviously, U&Es.